Good afternoon, everyone. This is Ted Baker, Chief Inspector of Hospitals here at the CQC. Thank you very much for joining our webinar this afternoon. We're going to be talking to you about our transitional approach and our strategy going forward. These are two very important developments here at the CQC, and I'm very grateful for you joining today so you can understand better what we're doing. But equally, there'll be a chance to ask questions and give us some feedback on what you think of our approach so far. Can we go to the slides, please, Steph? Okay, fine. So I'm going to be leading this webinar, supported by Kevin Cleary, our lead for mental health services. And Kevin will be presenting the transitional regulatory approach in a moment. I'm also joined, as you see on this slide, by several CQC colleagues. I'm very grateful for them for supporting the webinar. They'll be helping make sure that your questions are answered in the chat. Please do put questions in the chat. Kevin and I will answer some of them specifically, but those that we can't answer verbally, colleagues will try and answer for you in the chat. So please do feedback, make comments or ask questions as we go along. Next slide, please, Steph. So this is what we're going to talk about today. I'll start off by just reminding everyone about our role and purpose as a regulator, talk about the timeline of the changes going on at the CQC, and then Kevin will present our transitional approach, which is what we're using at the moment. There'll be a chance to break for questions after that. And then I'll be talking some headlines from our draft strategy, which has been published and which we're looking for comments on at the moment. And then just give you an indication of the way forward in the next few months. Again, there'll be some final questions, and I'll also share with you how you can get involved in giving feedback in the future. We will finish on time. We're due to finish at 3 o'clock and we'll bring it to a close on time. So thank you for your cooperation. Next slide, please. So our role and purpose to start with. Now, the CQC's role and purpose has been the same and will continue to be the same going forward. The regulations are not changing. The statutes in which we operate are not changing. We may be doing things differently, but the purpose underlying it will be the same. We're here to make sure that health and social care services provide people with safe, effective, compassionate, high quality care. And we want to encourage them to improve. And part of what I'm going to be talking about a little later on is how we can develop our strategy to strengthen the improvement arm of what we do. And that's going to be an interesting discussion when we get to it. Next slide, please. So our purpose is not changing, but the world in which we operate is changing. The services you provide are changing. They're responding to changing needs of the population, and they're responding to you learning to provide them better in better ways. We as a regulator have learned from our regulatory activity over the last few years, and particularly during the COVID pandemic, I should say, of different ways we can approach regulation. So we are learning. So there are lots of reasons why we do need to change. And the change program in the CQC, both at the moment in response to the current pandemic, but also going forward in terms of the strategy, is quite significant. And that's why this is such an important webinar for you to share with us. Next slide, please. Here's the timeline of where we are. This is a process that's been going on now for a year or so. At the moment, we're at the middle in phase 3 there, you see in the middle of the slide. And this is where we're using the transitional approach to a transitional regulatory approach for our regulation at the moment. And it's a transition in the sense of a transition from operating in a world in which COVID is active to our future regulatory model. The future regulatory model will come in May of next year in phase 5 there you see on the right. Phase 4 is the next step, which is where we'll be consulting from January on our new strategy and our way forward. And you'll be getting some indication of that in the next few minutes. Next slide, please. So first of all, our transitional regulatory approach. This is what we're using at the moment. And I'm going to hand over to Kevin to talk you through this. Kevin, over to you.
Okay, thank you, Ted. I will take you through our transitional regulatory approach, and we will have opportunity for some questions in a few minutes. Next slide, please. A quick recap. So we developed an emergency support framework that we used during the first wave of the pandemic. It had several elements to it. We were using and sharing information to target support where it was most needed, having open and honest conversations with providers, taking action to keep people safe and to protect people's human rights, and capturing and sharing what we did with people outside of the organisation. So our transitional regulatory approach replaces the emergency support framework, and it helps us to target our regulatory activity most effectively. Next slide. So Patient First shared practical examples from emergency department staff to help trusts harness the learning from coronavirus, suggests actions that can be taken at departmental trusts and wider system level to maximise capacity, maintain effective patient flow and keep staff and patients safe, recognising that emergency departments can be under particular stress. And it focused on 5 key areas: flow, infection control, reducing emergency department attendances so that people that were attending really needed to be there, staffing, and treatment of patients. Next slide. So assessment of mental health services in acute trusts. So we reviewed findings from over 100 acute hospital inspections, and we were looking at how well the mental health care system needs of patients were met and where trusts and the wider system needed to improve. So if you're working in a mental health service, you will know that there is a particular sort of stress point in acute trusts. We found that staff were generally caring and working very hard in challenging circumstances. However, too often it was the system that limited their ability to provide the best possible mental health care for their patients. We produced a report which outlines system-wide changes, trust-level changes and support for staff to improve the quality of care for people with mental health needs being looked after in acute trusts. Next slide. So where are we now? So as the risks relating to the delivery of health and care during the COVID-19 pandemic change, so we are now, of course, in the second wave and in another lockdown, we are looking at our existing methodologies and the learning from COVID-19 to pull together a transitional regulatory approach. So this will this will be the approach up until the implementation of the new strategy. And aspects of our approach will provide learning on how we want to regulate in the future. So we are in a continual sort of learning environment, building on what we've done up until now, but in a sort of iterative way, I'm using that learning to see how we're going to regulate in the future. And exploring our emerging strategic themes in more depth. Next slide. So during the next phase of the pandemic, the key components of our transitional approach will be a strengthened approach to monitoring. So we are keeping the existing key lines of inquiry. We will continue to monitor risk in the service. And a clear focus on those CLOEs, an inspection activity that's more targeted and focused on where we have concerns. So we will not be returning to a routine program of planned inspections. However, I can say that since the end of April, in mental health, we've carried out between 30 and 40 separate hospital inspections. So whilst it is a slimmed down program of planned inspections, we are actually very active on the inspection front at the moment, and we'll continue this, and we'll continue to adapt this approach. And we'll also be considering longer term changes to how we regulate, which we'll explore through engagement on a future strategy, and Ted will come back and talk a little bit more about that strategy in a minute. Next slide, please. So as I said, we're building on our learning from the emergency support framework, And using our key lines of inquiry, we are focusing on safety, so patient safety, access and leadership, increasingly looking at other areas like infection prevention and control, which are critically important in mental health services. We're looking at information from all available sources, including piloting new ways of gathering information from people using services and provider collaboration reviews. We're looking, I have to say, very strongly at whistleblowing complaints, incidents that are reported to us. Strong relationships with providers remain a key part of our approach, including regular calls. And a risk model is there to help us make better decisions, but professional judgment is very much a key part of how we will continue to monitor risk. New slide, please. We're not going to be returning to business as usual at the moment because of the risks that COVID-19 present. We're not returning to our fixed timetable or frequency rules on inspection. We will be focusing on hearing people's experiences, and on-site inspections are a very important, valuable tool, and we'll continue to use those to focus on services where we have concerns about the quality of care that is being provided. Next slide. We appreciate that ratings and information about our assessments remain vital in giving a view of quality. If during our transitional monitoring activity our review indicates a low level of risk, we will take no more action. Where our monitoring activity leads us to inspect a service, we'll follow our existing inspection methodology, adapted for the current environment. Although we will look at any or all of the key lines of inquiry and inspection, and we are flexible around this model, our activity is more targeted and focused on areas of risk. And that does mean that we will not always be able to change a rating. Our ability to re-rate is limited by the pandemic and our published methodologies. And if we were to change our approach to rating significantly, we would have to go out to a full consultation. New paragraph, new slide. Questions so far. So monitoring questions for NHS and independent healthcare providers are on our website, and we've got guidance on what to expect on the website as well. So questions.
Okay, so over to colleagues for questions. Thank you for that, Kevin. So our transitional approach to regulation is very different from what we've done before. It's very much a response to the COVID pandemic, but as I said, and as Kevin has shown, it's very much forward-looking to what our long-term strategy is likely to be in terms of our approach to regulation. We'll be learning as we apply it, but equally we need your feedback as we develop it over the next few months. Any questions on what Kevin or I have said so far?
Thanks. So I think we're waiting for some questions to come in, but we've got a couple. So there's one that's maybe a bit more operational, asking whether CQC requires ID verification for clients accessing psychological support through employee assistance helplines or psychological therapy.
Thank you, Sarah, for that. Can I hand over to my mental health colleagues on the call to answer? Can anyone answer that, or do we need to feedback separately?
I think we'd probably need to feedback separately.
Thank you. And also a question on whether there are any plans to inspect the quality or effectiveness of counselling or psychotherapy.
Not at the moment. This is something we have reviewed over the time, but we haven't. We're not anxious to extend our regulation into that area at the present. Kevin, do you have any comments on counselling and psychotherapy?
No, I think we have had discussions about this. It is what seems like a simple area becomes very complex very quickly. I think if we were going to look at regulating services, the first thing we would look at would probably be IAPT. So immediate access to psychological therapies we will look at in the future.
Thank you. And then a question, will changing ratings as part of focused inspections be part of the formal consultation in January?
Two answers to that. We can change ratings as part of focused inspections at the moment if we have to take regulatory action. If there's been a breach of regulations, that will affect the ratings. But of course, that only means that the ratings will go down, not up. And what we're very keen to do is to create a ratings process during the transitional process that enables people to show improvement as well as show any deterioration. So we're very keen to develop that. That does need some more work though, because it is important that ratings are rigorous and valid and meet the same level as previous ratings, so that there's kind of continuity of the value of ratings going forward. So we do need to do more work on that. And if we need to change our regulatory assessment framework in order to do it, then of course we'll come out to consultation. So it is very likely that there will be some aspects of forward looks for ratings in the consultation on January to answer your question. As yet, that is to be determined though.
Great, thank you, Ted. How can trusts improve their rating without an inspection? And if CQC will only be focusing on areas of risk?
And that's exactly what comes back to what I was saying a few moments ago. So it's a very good question, and I think an important one, because I'm very conscious of the fact that trusts and other providers want to demonstrate that they've improved where they have improved, and we want to be able to demonstrate that for them. But in order to do that, we need a different approach. What we can't do is go back to the old comprehensive inspections, one, because of the pandemic and the risks associated with that, but also we don't, our future strategic direction is not to revert to the big comprehensive inspections. We want to be much more agile and focused in our inspections going forward, but equally we want to be able to provide up-to-date ratings. And we are looking at the moment at how we can provide up-to-date ratings during the transitional approach, so over the next few months. And as I said, proposals for that will come forward, and that will be ratings that can demonstrate improvement as well as deterioration, but also how we can create real-time ratings, what we call real-time ratings, but up-to-date ratings going forward, beyond the transitional process as we go into our new regulatory framework. And I think we're very keen to move into a new regulatory framework that does provide much more up-to-date ratings. We've heard from providers and we've heard from people using services that they want the ratings to be up to date. They don't want ratings to be a year or so old. So we're very keen to explore how we can do that. It does mean a different approach to ratings, and as I was saying a few minutes ago, almost certainly we'll want to do some consultation on that in the new year.
Thank you, Ted. And a couple of questions on the PIR. So whether trusts will be expected to submit PIRs.
Kevin, do you want to come in on that one?
Yeah, sure. So the short answer is no, we're not expecting trusts to submit PIRs. The feedback that we got from trusts around the large planned inspections was that the PIRs represented a significant burden, and we have listened to that, and wherever possible we will not be asking for PIRs because they're not normally part of a focused inspection. That's not to say we won't ask for information. We will do, we can do, and I have done in the last few weeks, but we will not be asking for large PIRs anymore for now.
Thank you. And then questions around whether the changes apply to private providers, and I think in a similar vein, whether the same criteria applies to newly registered services.
Sorry, Kevin, you answer it.
Okay, all right. So the transitional approach is for all providers. so independent health as well as NHS trusts, and we have had some significant inspection regulatory activity in the independent sector in the last few months, and the rules that apply to newly registered providers are the same as they are for current providers. So there's no change in our approach.
Thank you. And a comment that not reviewing ratings will also impact on new tenders, and whether CQC is communicating our changes with commissioners.
Yes, very much so. We will be consulting with commissioners going forward, and I think the issue about ratings is important. I mean, clearly people need to understand that faced with the pandemic, circumstances have changed, and I think everyone, including commissioners, need to be aware of that. But having said that, I think it's part of our purpose to provide ratings for services, both for the providers and commissioners, but also for people using services. So we think it's very important we get back to that as soon as we possibly can, and that certainly is a priority for us.
Thank you. And we mentioned that the monitoring questions have been published. A question on how we plan to roll these out to providers in a time frame. So I think this is about when providers can expect to be contacted.
Well, my colleagues are using the monitoring questions at the moment, and they will have a programme of contacting all providers eventually over the next few weeks and months. I mean, clearly it takes time, but we will be trying to reach out to all providers using this monitoring process, the structured monitoring process, to make sure we have a sense of the issues facing them, but also be able to assess the risks in services and make decisions about what regulatory activity, if any, is necessary.
Thank you. And a question around whether we have published reports on findings for mental health trusts during the pandemic, or whether we plan to.
Kevin, do you want to answer that?
Yes.
We've published reports on mental health trusts, haven't we?
We have, yes. So we have been publishing reports. We have published a number on NHS services and independent health services. So the fact that we're doing a focused inspection doesn't mean that there isn't a report at the end of it. There is. It may not result in a re-rating, but there is a report put on our website which is shared with the provider.
What we're not doing, of course, is going back to providers on a timetable basis. At the moment, we're going back where we perceive there to be risk, and that is very much the difference.
And a question on how will CQC be listening to patients' experience? Will this be by community surveys or other methods?
I think, as I'll say in a few minutes' time when we talk about our strategy, listening to patients and service users is really very central to the way we want to approach regulation going forward, and we want to see services through their eyes rather than through the eyes of the system around them. So I think this is a big challenge for us, and of course this has been difficult during the COVID pandemic because of the practical problems during the COVID pandemic. Over the last few months, we've launched a new web portal called Give Feedback on Care, which has proved very popular with patients and service users, and we've had a lot of increase in feedback we're getting from patients and service users, and that has really been very useful to us in assessing risks going forward. I think we are building assessment of service user voice into our monitoring approach, and we are developing tools to do that at the moment. So that is going to be central to some of the work we're doing over the next few weeks. Assessment of the patient voice is very important, and we will be piloting various approaches to see which is most successful. Some of it can be done by surveys, and some of it can be done by, as I say, the web portal, or by having virtual focus groups with patients. So we're going to be exploring all those kind of options. One thing I would say, and I've said this to acute trusts yesterday, and I'll say it to you today, is one of the things that I think disappoints me about what we've found over the last few years in our inspection and assessment of providers is how little they do to assess patients and user voice opinions of their services. It tends to be just what they're contractually required to do rather than exploring new ways of doing it. So I would throw the challenge back to you. We as CQC need to listen to patients and service users better, but is there any way you can do that better? Because I think from our perspective, it would be much better if we could see that providers are leading on this, and we can understand the patient, their patients' views on their services through the work they've done, rather than us have to do it separately. So I've thrown the challenge back to you, but it is very important, and it will be central to our work going forward.
Thanks, Ted. And I think probably final question for this section around it's a question around our plans for the well-led element of inspections now that we're in now we're using a transitional approach.
The well-led part of our inspection will continue. We'll be doing well-led inspections on a risk-based and responsive approach, and where we do well-led inspections, they will tend to be focused on specific issues, and we have done those over the last few months where we found issues that we need to address through the well-led key question. So just as we could do safety-based inspections, we will do well-led based inspections as well in terms of the focused inspections. So they will go forward. What the well-led did under the previous approach, when we did the comprehensive inspections, was the well-led, if you like, was the final part of an inspection that led to the overall rating for the provider. So we will explore how we're going to use that assessment of well-led in our ratings going forward. I think all I would say at this stage is that well-led, the leadership and culture of organisations, is very much fundamental to quality, and I think will remain a very important part of our assessment of all organisations going forward. So we've learned over the last few years that well-led is an important area to focus on, because without good leadership, without good culture, then other aspects of quality are just not delivered. And it is really central to our assessment of providers over the last few years. Okay, Steph, no more questions. Shall we move on then to the strategy? Is that all right? Okay, thank you then for those questions. You'll be a chance to ask some more questions in a few minutes, but I just wanted to talk to you about our strategy going forward. Now, the strategy in draft form has been circulated. This is just a discussion document at the moment, and I'll explain it towards the end how you can give feedback on that if you haven't already seen it. The formal consultation on the strategy, where we produce a final draft of it for formal consultation, will be in January of next year. So if you've missed it this time, there will be a chance next time, but please do see if you can search out the discussion document at the moment, because we're very keen to get you involved in developing the strategy before it gets too far towards its final draft. Now, we recognise that as a regulator, as I said right at the start, that we need to change. We need to change not because we want to achieve different things, but we recognise, and we've learned from our experience over the last few years, that we can deliver our purpose better. But we also need to respond to the changing world in which we operate, the changing services, our changing understanding of it, but also the changing demands of people using services. So we think it is absolutely essential that we do change our approach in this strategy. And you'll hear this strategy is really very different from where we have performed regulation over the last few years. It's got 4 themes to it. The themes haven't got their final names yet, but at the moment we call them people, smart, safe and improve. And I'll just discuss the strategic ideas behind those themes as we go forward. Next slide, please. So the first theme is people. And as we've already touched on, I think there's a real sense we want to see the quality of services through the eyes of people using those services, rather than through the professional eyes or the provider eyes. So essentially, we want people to tell us what they think about services. We want to understand how they experience services. And we talked a few moments ago about the importance of listening to their voices. And of course, that is going to be absolutely central. But equally, we need to understand that people don't necessarily see services as being focused on a particular provider. And people often receive services across several providers through a pathway of care or through a system of care. And so looking at services through people's eyes, we have to look at it from a pathway or system perspective to understand what the experience of care for individual patients and service users are. And that's going to have to be changed the way we approach things. So one of the things we've got to do is become much more system focused. Kevin talked earlier on about a care of people with mental health needs in acute hospitals. And that's just one example of where we've already started moving into that area. People in acute hospitals often have mental health needs, and we've challenged those hospitals. How do they work with their mental health colleagues to make sure that people are getting the right care? And of course, the same would occur in reverse. How do people in mental health facilities get good physical care? That integration and joined up care is really going to be very important. But also, how do people get care flowing from primary medical services through community services to inpatient services if necessary? How do people experience that pathway of care? Are they getting the right care in the right place at the right time? And I think that is going to be really very much a focus of what we do. So when we look at individual providers, we're increasingly going to be asking not just how do you provide care, but how do you work with other parts of the system to make sure care is joined up and people are getting the right care for their needs. And I think that's going to become an increasing focus. So our key lines of inquiry are going to have to reflect that. And that's going to be an important part of the way we take things forward. Another important aspect of this, which has really come to the fore during the COVID pandemic, is the fact that people suffer inequalities of care, inequalities of access to care, but also inequalities of outcome of care. So how can we make sure that when we look at providers and the quality of care they provide, we take into account how they make sure that the people in their population, their local population, are receiving care in a way that reflects their different needs and any barriers they may face to accessing care, so that we can generate more equality of care and equality of outcomes of care going forward. So this is a very important part of what we're going to be looking at going forward, and we'll be asking providers again, how are you tackling inequalities of care in your area? How are you working with colleagues in other parts of the system to tackle inequalities of care? And how are you making sure people get the right care for them? Next slide, please. So SMART is about smarter regulation. It's about how can we become a better regulator in terms of the regulatory bit of what we do. And again, there are a couple aspects of this. What we've learned from the transitional approach and from the emergency support framework is how important that relationship between us and providers is. If we can have an open, honest, transparent relationship with providers, then that gives us much more confidence about how we can regulate with them. And I think one of the things that we've been working over the last few years, and one of the things we need to take forward in this strategy, is building up really positive, constructive relationships with providers. And so as a regulator, we want to be seen more as a partner than, if you like, someone outside who comes in and criticises. Now, of course, if we don't develop those good relationships with providers, then we are left to be making judgments from outside. And that's a much, if you like, more compliance-driven model of regulation. And we want to move on from that wherever we can. It does depend on providers and the regulator working together to make this work, which is why it's so important that you understand our approach and help us support it. One of the other things about smarter regulation is about better use of data. Someone asked a few minutes ago about PIRs, and we recognise, and Kevin highlighted the fact we recognise PIRs are often a burden for providers because we're asking for a lot of data so we can understand the risks in their services. How can we do that better? Well, there are several things we can do. And again, during the COVID pandemic, there's been a lot of sharing of data between the national bodies. And I think we really welcome that. And that's really helpful. We want to build on that. So we want to build up alliances with other national bodies so that we understand their data and they can understand our data, of course. We also want to use that data primarily in our assessment of providers and not have to go to the providers and ask them to, on a transactional basis, to provide data for us regularly. So to remove that burden, that data request wherever we can. I don't think we'll ever be able to stop asking for any data, but we want to reduce it to an absolute minimum where it's really essential. So we need to understand what is the data that really helps us understand risk in that provider and not ask for unnecessary data. I think if you take this forward to its logical conclusion, what we would like to do is get to a position where we can move on from the transactional relationship around data to one where there's an always on approach to data, and that we can access data from the provider systems all the time. That enables us to see the data that you're seeing so we can understand risks as you see it, and we can, through our what hopefully will be a positive, constructive, supportive relationship, be able to discuss that with you in a way that enables us to be confident that you're managing it effectively, but doesn't add a burden onto you. So how can we create this always on view of data in providers rather than moving from the individual transactional approach that we have at the moment? Those are aspects of being a smart regulator, better use of data, building really constructive relationships with providers. Next slide, please. Safety. Now, safety is one of the key questions that we ask, one of the 5 key questions we ask, and it is the key question that we have the most concerns about. It's the key question. It is the key question where we most often cannot answer, yes, this service is safe. And we've been really challenging ourselves about what we can do differently around safety. And I think one of the problems is that we, and I think health systems generally, tend to have a very process-driven view of safety. Safety is about doing the right thing, whatever the process is, having a protocol, a policy, checking the tick boxes, whatever. Now, I think processes are really important in safety, but they only work if you've got the underlying safety culture right. And I think what we want to do going forward is to focus on the safety culture. And that means, of course, and I'm sure you've been involved in discussions about just cultures and no blame cultures. So cultures where people don't feel threatened when things go wrong. Cultures where people recognise that things do go wrong in complex health systems, but something going wrong isn't the failure. The failure is not learning from something going wrong. So moving to a culture in which people understand the risks of what they're doing, but also are committed to driving down any preventable harm. Not because they believe that preventable harm ultimately can be totally abolished, but they believe that focusing on preventable harm and reducing it is a constant feature of a safety culture. Some of that has to be about building a culture where people can speak freely about their concerns. And I think one of the other encouraging things during the COVID pandemic has been a sense that frontline staff are raising their concerns more freely, both within providers, but also with us. And we've had a big surge in the number of staff raising concerns with us during COVID, and we welcome that. We welcome it because it means people feel they can talk up about concerns and we can respond to those effectively. But equally, we want them to be able to raise those concerns internally within organisations so that you can respond to those concerns effectively as well. So creating this freedom to speak up culture, this just culture, this restorative culture, and this culture that has the humility to recognise things will go wrong, but actually the challenge is to learn from those things to reduce preventable harm to an absolute minimum. Those are the kind of things we want to explore. And when you've got the culture right, then the processes will work. And we think a step change in safety is possible in healthcare if we approach this the right way. And we want to be part of a collaboration working with you, the providers, but also working with some of our national partners to make sure that we're all consistently approaching this in the right way. Next slide, please. So improve. Now, one of the things that we often get criticised for is that we go in, we see problems, we report on those problems, we tell the provider they've got to take action, but then we step back and leave the provider to find out how they're going to address the issues. And people say, why aren't you doing something to help the provider improve? And the answer to that is really that there's a conflict between us telling providers what to do to improve and holding them to account as a regulator to improve. So our regulatory position makes it difficult for us to be a direct improvement support agency. But we recognise that in all sectors, providers want stronger external support to help them to deal with issues they face, be those issues that we've identified or be they issues they've identified themselves. And so what we want to do is to form what we call an improvement alliance. An improvement alliance with different parts of the system, be it NHS improvement for NHS services or be it other parts of the system, to make sure that providers have access to improvement support when they need it. And we want to be an agent to help people access improvement support, not an agent that tells them how to improve, because that would conflict with our regulatory activity. And we think this is really very important going forward. And of course, there are some sectors that have actually got a lot of improvement, such as NHS improvement for NHS Trust. There are other sectors that there's very little in the way of improvement support for them. And we want to help those sectors find the improvement support so that all health services have access to specialised improvement support. And some of that may be from other providers. And one of the things, of course, we can do, and we've tried to do in the past, but we need to do better, is to identify those providers who've solved difficult problems and encourage them to share their learning with other providers so that everyone can learn from the best. So that's very much where we want to be with improvement. And I think it's a very important part of what we're doing going forward. Next slide, please. So that's a very quick summary of our strategic plans. As I say, there's a discussion document there at the moment. Please have a look at it. It'll give you more detail behind what I've said, and do feedback any comments you have for us. Where are we going next? Well, we're going to develop the transitional regulatory approach with further iterations, learning ourselves as we develop it to make sure that it becomes a really strong regulatory tool by the time we move into our permanent regulatory model in the middle of next year. And there are various things we have talked about that we recognise we need to do, such as people's voice, listening to people using services, and the issue about ratings, which I've covered, and we recognise that we've still more work to do in both those areas. We'll be formally consulting on the final draft of our consultation in January, so please do give back your formal feedback on that. We value it, and please do recognise how you can help us implement it really effectively. Once we've got that formal consultation, once we've been able to respond to it, we'll then be developing plans to implement our new strategy. As I say, in effect, it's beginning to implement it with a transitional approach, but we'll be formally implementing it from next May forward. It's a 5-year strategy, so not necessarily everything will change at once, but we're very, very committed to making sure it is implemented fully over the next few years. Next slide, please. Where's the future? Well, I've talked about the implementation there. We will be clear how we're going to do it. So there'll be more consultation about the process of implementation going forward, and we will do our best to keep you informed. And we welcome your feedback. Next slide, please. OK, so that's all I want to say about strategy. I hope you have a sense of the nature of the change at the CQC and the ambition of that change. We want to be the best regulator we can, and we want to learn from what we have achieved in the past, but also build on the successes, but learn from the things we can do better. And I think we've highlighted some of the things we can do better as we've been talking today. So any feedback or comments are welcome. Any questions you want to ask, please do on the chat.
Thanks, Ted. So we've got a question around whether the well-led assessment will also focus on system leadership and governance, given a moving focus towards system collaboration. I wondered if you wanted to speak a bit about this and maybe some of our ambitions when it comes to systems.
The well-led assessment will, I think, the well-led framework we introduced in 2017 jointly with NHS Improvement. It was a big move from the well-led key question we'd had previously to look at incorporating elements of culture and leadership culture and values and quality improvement methodology. And so I think 2017 was a big step forward. We are now working with NHS Improvement for the next stage of that well-led framework. And some of the things I've been talking about have been built into that. And one of the key things is going to be the system focus. So we're getting to a point where in order to demonstrate you're a well-led provider, you'll have to be able to demonstrate your engagement and your leadership of the system and making sure that the system is delivering consistently for people who you serve. So yes, the well-led framework and the well-led assessment will very much have a system focus going forward. Lots of other things. We want to look at the culture in the organisation as well. It won't be purely about systems, but systems will be an important part of it.
Thank you. And there was a couple of comments and questions around whether we could share good practice, and particularly whether CQC could suggest organisations who could learn from each other in areas of good practice and shared learning.
I think that is very much something that we need to do, and as I talked about, our strategy is something we want to build on. We have done some of that already, so it's important to say that we haven't. This is not an area we've totally neglected. We've done some of that already. Kevin, do you want to talk about any of the reports we've produced around good practice and what we've learned from the better providers?
Yes, certainly, Ted. So I think what we've learned is that the better providers are ones that are actively listening to service users and incorporating that feedback into how they think about services. I think the better services also have been using service users and patients to actively help design parts of the care systems. They are involved in quality improvement within organisations, actively involved. So that's not sending out a questionnaire and asking patients or service users in a mental health service what they think about X or Y, but actually getting the patients actively involved in the quality improvement processes. And there are some organisations around which I think do this very well. I think the better providers are ones that we have seen that actively are looking at the culture of the organisation, aspects of the culture of the organisation. So, for example, there are very well developed safety culture tools which tell you about the culture within your organisation in relation to patient safety, and use that as the basis for their quality improvement work. I think that we've also seen that organisations which are interested in the wider system, in the sense that they're concerned about mental health inequalities within the sort of general population, and are thinking about how they can improve that in partnership with other partners. So they may be governmental partners, or they may be non-governmental organisations, that they perform more highly. So I think you will see a sort of continuum. What we've seen when we go out is a sort of continuum between organisations which are very insular and very inwardly focused, and then others which are much more interested in sort of problems in the wider community. Not that they see themselves as the body that's responsible for that, in the sense that they're to blame, but actually that they see themselves as part of the solution, but only doing that in partnership with other providers. And those organisations are are sort of beginning to actively make a difference to the system. So as Ted was talking about health inequalities yesterday, there's a report coming out from the Centre for Mental Health in the next 48 hours, if it didn't come out last night, about this very issue, about how you get change in relation to health inequalities, mental health inequalities, which does require a system-wide change. And it's variable across the country at the moment in what you see, the work that you see that's been undertaken in relation to that. But actually, I think one of the things that sort of we could look at, as part of improvement is actually how do you coach a board, a trust board, to be interested in things such as health inequalities and to actually actively engage with it. Interesting times. But I think we do see some really good practice, and we're happy to share that.
Thank you.
In all the reports we produce, we try and always give examples of good practice, and I think we need to do more of that. But I think what I'd like to do is get to a position where if a provider has a particular issue, we can point them towards where they can get the best advice and support to drive that forward. And that is often going to be other providers who've demonstrated they can address the issue themselves. So I think that's real opportunity for us going forward. Sorry, Sarah, you got to come in. Another question.
Yeah, that's fine. So couple of questions that I'll bring together on a bit more around the data. So one saying that obtaining data for private providers is harder than for NHS trusts. Wonder how that might affect using existing data to assess a service. And then a secondary question, but also linked to data, about whether we'll be using the Onsite report to identify risks, even though it's a bit out of date, but improving all the time.
Well, thank you for that. And the Onsite reports are going to be the basis for developing our risk assessment, but we're talking about taking it to a much more real-time approach. So to answer your question about it being out of date, and I think one of the problems that we do have is a lot of data we look at is a bit historical, and so while it is valuable, it's not giving you a kind of up-to-date view about what's going on in this provider now, which then leads us to asking for PIRs, and because we want up-to-date information. And I think what I want to do is move away from that, so the data we have is more real time, and I think that is very much the aim on that. Sorry, what was the second part of the question, Sarah?
Second part of the question was about
data independent providers. Yeah,
that's it. Yeah.
Okay. Well, I think this is a big challenge. I think for many of the NHS trusts, they will have a lot of data which we can call on, and as I say, if we can open a kind of real-time access to their data, that can remove this sense about we're always asking for reports, etc. We can see things through your eyes and understand the data, and hopefully interact with you and support you on your reaction to it. I think for independent providers, and of course it varies for different independent providers, there is less data. I think that is true. I think we as a regulator need to challenge those providers. What data should they be collecting in order to assess the quality and monitor the quality of their services? And we need to work with them to make sure they are collecting the right data. And so I think that is going to be more of a challenge. But equally, we as a regulator need to be supporting them to find the right way of collecting the right data, because otherwise, I think we're basically accepting a situation where the data doesn't exist to monitor the quality of care as well as it should, and I don't feel comfortable with that. I think we need to challenge the sector to make sure it is collecting the data, and the fact they're independent health and not NHS trusts should not change that fact. We're always, our principle is always we regulate services in similar ways and apply the same standards, be they NHS provided services or independent provided services, and that's something we will stick very firmly to.
Thanks, and I think probably time to squeeze in one more, and that's, will the special measures and enforcement policy be changing as a result of the strategy changes?
Okay, the enforcement policy is based on our fundamental standards. So the fundamental standards are not changing, and we will still be applying those. I think I suppose the point we want to make is that enforcement of those standards is necessary part of regulation. We don't think it is the fundamental thing that changes services for the better across the board. It only influences the areas where we take the immediate enforcement. So enforcement will continue. And clearly our priorities for enforcement may change depending on what we see as risks in the system, but fundamentally I don't think it will change. The special measures is slightly different, because special measures of course is an NHS improvement intervention, not a CQC intervention, although we will often recommend special measures to NHS improvement. We are working closely with NHS improvement to develop different forms of intervention that can be based around systems as much as individual providers. And I think you'll be hearing more about that over the next few months. So in a sense, special measures will still probably be in the armamentarium, but we will be looking more for system interventions wherever possible, because I think we recognise that for certain providers, the problems they face are a reflection of system problems as much as problems within the provider. And we need to acknowledge that, and NHS improvement with their intervention need to acknowledge that as well. Any more questions, Sarah, or shall we move on to the get involved slide? Shall we go to the get involved slide?
Yes, I think that might be all we have time for questions wise, but just to say that the questions are couldn't answer today, we are taking them back and we'll be feeding them into the right people, so it will be influencing our work and how we develop. Okay, everyone, there's a lot there, and I hope it's been clear to you. But as I say, I think the most important thing is to understand our ambition to move forward. We're ambitious because we're ambitious for the services you provide, and we want to play our part in helping you provide them to the highest standard, which I'm sure is what you want to do. Please do feedback. Here is how you can get involved and feedback. These various links will help you get involved. The Citizen Lab link at the top will take you to where the discussion document around our strategy is, if you want to see that. And then you'll be able to keep up to date with blogs and provider bulletins there. I noticed one of you said that you get an awful lot of information from us already. I'm sorry if we send you too much. Please do filter out what is important to you. I recognise how busy everyone is and the amount of emails and other contacts you get, but we're very keen to stay in contact with you all. You can stay up to date with our Twitter account or with CQC Connect there at the bottom. So please do take a note of those links and stay in contact with the information coming out from the CQC. OK, that is the last slide. We're coming to an end now. It's just coming up to 3 o'clock. So thank you very much for joining us. As I say, do stay engaged with us and send us any feedback you think is important. Do get involved in the consultation going forward. And I look forward to working with you all as we go forward into the new year and to the CQC strategy launching next year. Thank you very much indeed.